Great to be with you. Peter Barlis here, cardiologist, and it's been a while since I've posted a video. Not to say that I don't appreciate the support that you've given the channel. It's been certainly an immensely busy time period with a lot of patients, procedures, a lot of research trials that I'm trying to coordinate and get up and running with some possibly new technology, and something that I look forward to sharing with you over the coming few months about some new methods of looking at heart disease with a different type of scan. But I must firstly say how humbled I am to see so many of you that come and see me as patients for opinions from around Australia and the world, in fact. And I've been humbled by the messages of support, whether it be you've learnt something on one of the videos that we've had, whether it's a calcium score video, recovering after a heart attack, having a heart stent. You found that useful. You found that, something that hopefully has given you some comfort. And that's what it's all about, is giving you comfort, giving you reassurance in everything that we do when we're tackling heart disease. So a common topic, as you've seen over the years now with the channel, is related to heart stents. We've got almost 2 million views on our video dedicated to heart stents. And in 2025, I guess the question becomes, do you need a heart stent? Or are there any other alternatives? And I've had many of you reaching out telling me about other procedures that you've had, particularly with something called drug-coated balloons. So I want to look a little bit deeper into what this technology is, and is it a potential replacement for a heart stent in the future? We've observed through many of our videos what heart stents are. Just to summarize, these devices are a spring, most often made of metal, that essentially expands to open up an artery that has had a buildup of plaque. Plaque can be a mixture of things: fatty material, lipid, can be calcium, can contain a lot of inflammatory cells, and these plaques, as we've addressed before, occur because of several cardiac risk factors. But when the plaques cause a restriction in the blood flow to the arteries that supply the heart muscle with the blood, then essentially you can get angina or chest pain, or you might have a heart attack. And these stents are used to open up these arteries. Now, modern day stents, or what we call drug-eluting stents, or DES, are extremely safe and really the mainstay treatment when you need to have a stent. Previously, we used to have what we call bare metal stents. Now, I can't recall the last time I put a bare metal stent in, and the results of bare metal stents are not as favorable as drug-eluting stents. And the results of drug-eluting stents means that this essentially has replaced the treatment of patients needing stents, whereby you would have a drug-eluting stent. Now, drug-eluting stents mean that there is a drug coating the outer surface of the stent. When it's expanded and placed in the artery, that drug gets absorbed over weeks and months to help reduce the body's inflammatory reaction or inflammatory response. And that therefore reduces the risk of that stent narrowing or closing off as the stent heals. Now, although stents are very safe, when I say safe, less than 5% risk of things like restenosis or re-narrowing happening, or even less common is a complication known as thrombosis or a clot forming inside the stent, these risks are nonetheless still real. And the holy grail of what we do as interventional cardiologists is to obviously avoid putting a stent. So that's what I tell my patients. The stent is the easy thing to do, but the hardest is often controlling the risk factors, reducing the complications that can occur inside the arteries, treating you with specific medication to help reduce the risk. And of course, when and if a stent is needed, then we've got to look at, are there any alternatives? Now, it's still early days. I must temper the enthusiasm. Many of you have reached out telling me, look, you've had this drug-coated balloon technology placed around the world, and particularly around Europe. There are many sites, and a lot of the trials that have been done occurring in regions like Italy, whereby we are using these balloons as possible replacements for heart stents. Now, it's not for everybody. So let me tell you a bit about what these drug-coated balloons are. Now, these balloons are essentially a balloon that goes into the artery and is expanded to open and prop open the artery, but the balloon does not have a stent on the outside, so it does not leave a stent behind. So what the balloon has is a particular drug that is coated around the balloon. And that drug can be similar to some of the drugs that we actually use on these drug-eluting stents. And their aim is to reduce the risk of the body's reaction against what we've done. We put the balloon in, and to reduce the risk of that artery closing down. Now, traditionally, these drug-coated balloons have been the mainstay treatment for those patients who come in with what we call restenosis. Restenosis being the re-narrowing of a previous heart stent. So if that stent has unfortunately failed and you've had tissue building up and therefore you get a lot more symptoms, then rather than putting another stent inside the previous stent, we can use these drug-coated balloons to target the delivery of a drug to help reduce the reaction and reduce the risk of re-narrowing. Over the last couple of years, however, there's been a lot of interest in using these drug-coated balloons in diseased arteries, but not leaving a stent behind. Now, as I said, it's not for everybody because specific types of arteries have different sizes. They can have different types of plaque. They can have a lot of calcium. And often these balloons, by not leaving a stent behind, mean that you don't have the support of a metal spring in the artery, and therefore there's a higher risk of the artery closing down again. So they might be suitable for where you might have soft bits of plaque that don't have a lot of calcium. Well, you might get a good response by putting this balloon. Now, traditionally, when we used to use balloons without drugs, the risk of re-narrowing and closing of the artery was exceptionally high. So we wouldn't do that in modern day practice now. We wouldn't just use a plain balloon without any particular drug, because we know that although you might open the artery immediately, there is a very high risk that that artery will close down again very soon. So the use of these drug-coated balloons is certainly very attractive. But as I said, it's not for everybody. I want to go through a little and show you some research that's been done that we're actually privileged to be part of here in Australia, based on some work that my former PhD mentor and supervisor, Professor Patrick Serrois, has been undertaking. And that is using these drug-coated balloons as a possible replacement or alternative to stents. And I want to show you what actually happens when you put a balloon in and what some of the problems might be. So if we look here, this is Professor Patrick Serrois, who presented this work last year in one of the major international conferences, the EuroPCR. And essentially what he shows, that there are still several unresolved questions on the use of drug-coated balloons. Now, this is a picture here of what we call OCT, or optical coherence tomography. It's a high-resolution scan of the inside of the artery. And what you see is that you get a balloon placed inside an artery, and when the balloon is expanded, it actually causes these microscopic tears or dissection inside the artery. And this little, we call flap or dissection flap. And our work is actually geared towards looking at how these dissections affect blood flow in arteries and which particular types of dissections or tears would need to be treated with the stent and which you might be able to leave and that potentially will heal naturally. But when you look at a drug-coated balloon and when you expand it inside an artery, you do get these tiny little tears occurring inside the wall. And that has been the major problem of just using a balloon. You essentially leave these microscopic tears to heal, but in healing, there's a higher risk of re-narrowing and the artery closing down again. And that's where we've traditionally relied on putting a stent in to keep the artery open and stop it from closing down. But if we look again at these arteries, this technology potentially offers the opportunity to scan using this technique, and you can actually see these, now these are all microscopic little tears, but these are little dissections that occur within the artery. And potentially leaving those over time, we see that the artery tends to heal naturally. And that's a little dissection you can see here. The balloon has gone in and opened up this area of narrowing, but it has caused a little bit of trauma in the artery called a flap or a dissection flap. But we're seeing that potentially by using this drug over the balloon, this drug can help mitigate this risk. Now, this is new technology. It's not for everybody. There is certainly some promise in this, whereby you might be able to treat the artery, deliver a drug inside the artery that reduces the risk of the artery closing down and allows better healing, more natural healing, and minimizes the need for a stent. Now, when do we need to put a stent in? If the artery is dissected with that little tear that extends over a long segment of the artery, then it's often not safe to just leave it and heal naturally because there is a high risk of that artery closing down, and therefore we would need to place a stent. If the artery has a lot of calcium, as I mentioned before, and calcium is what essentially makes up our bones and teeth, well, this is a very hard material, and sometimes by putting a balloon in, we're not able to achieve an adequate expansion of the artery to restore normal blood flow. Well, then in that case, we will also need to put a stent. So, drug-coated balloons offer a lot of promise. Well, I see that the landscape in interventional cardiology will no doubt change, with more and more emphasis on minimizing the need for stents, but carefully selecting which patients actually would benefit from a stent versus those who would benefit from just using a drug-coated balloon. Now, when would I use a drug-coated balloon alone? Well, potentially in a smaller artery. They have been shown to be very, very useful. As I said earlier, in cases whereby a patient has had an old stent that has failed or re-narrowed, a drug-coated balloon is an excellent choice for improving symptoms. In arteries that might be towards the bottom part or in smaller territories of the heart, balloons on their own with the drug might be an appropriate strategy. And in some cases, after an acute heart attack, potentially where there's no major narrowing or there might be a soft amount of plaque, there has been some data to suggest using a drug-coated balloon alone, if you're able to achieve a nice result by expanding the artery nicely just with the balloon, might mean that you can avoid putting a stent in. So that's a lot to take on, and I'll have a few more videos on drug-coated balloons and to share with you some of the research that I'm involved with to look at how these balloons might work and which patients might benefit more versus those who actually would need a stent. But it's an exciting technology. The landscape is moving very, very quickly ahead, and great to receive all your messages and comments about whether you've had a heart stent or one of these drug-coated balloons, and I look forward to sharing a bit more about this technology in upcoming videos. So until then, bye for now.